So this is the falx cerebri, okay? You can see that it spans the superior portion, okay, all the way to the inferior portion here, all right? And also courses forward, that is anteriorly, okay? And therefore, it's also going to connect to the crystal galley of the scalp, then all the way to the back here also. Then you can also see this one, which looks like it's transverse in nature, okay, or appearance. That is the tentorium cerebelli, okay, tentorium cerebelli. So obviously we expect that this will separate the cerebellum from the rest of the cerebral hemisphere, okay? So the cerebellum will be lying within the posterior cranial fossa there, okay? And then it will be covered at the top, okay, or separated from the cerebral hemisphere, okay, especially the occipital lobe portion, okay? All right, so this is also worth noting. Then the falx cerebelli, okay, as the name implies, cerebelli, it will be separating the cerebellum, okay? So look at the difference. This is falx cerebelli, and that is falx cerebri, okay? So the cerebri will separate the cerebral hemisphere, and then the cerebelli will separate the left and right cerebellum. And you can see that here. The dashed line shows that it is hidden, okay? That is what is hidden here. It is hidden by the tentorium, okay? But those who are observing critically towards where the cursor is pointing at, you see that there is a slight, demarcation there showing that dura infolding, okay? So you saw this earlier on yesterday, where the periosteal and meningeal layers of the dura separate at this point to form a sinus. So this is the superior sagittal sinus, okay? And you can see that this is separating, so this will be what? The dura infolding that is separating the two hemispheres, okay? Which is what? Let's go back. The falx cerebri, okay? So you can see that. All right. Obviously, you can see the subarachnoid space, okay? And you can also see blood vessels, okay? The veins and arteries. Okay. For the pia mater, we know that it is closely invested with the substance of the brain. So it is not easily detachable from the brain itself. Once you detach a pia mater, it will come off with some of the soft tissues of the brain, okay? So note that as well. So this is a very easy way to capture the assignment I gave you yesterday, as in you going to look out for all the foramina or canals or apertures within which structures pass through. So that is the olfactory bulb, olfactory nerves are there that will pass through the cribriform plate, the foramina within the cribriform plate, okay? And when they come out, this olfactory bulb will be formed. Then this will be the optic nerve, okay? Then you have a superior orbital fascia here that is containing 3, 4, 5, and 6. That's the cranial nerves, okay? 3, 4, 5, and 6. I've already told you that for the 5, as you can see here, it is the V1 that will pass through superior orbital fissure, okay? V2 and V3 will pass through different apertures, okay? So look out for the foramen rotundum and then the foramen ovale, okay? And look out for which of the V2 or V3 passes through them. Then also you have once you've looked at 3, 4, 5, and 6, 6 is abducent, okay? So you know that the abducent will also pass through the superior orbital fissure. So you'll be left with what? The 7. So 7 is fascia, which is located here, okay? Facial nerve, and then the vestibulocochlear, right? So facial nerve and vestibulocochlear together pass through the internal acoustic meatus, okay? Internal acoustic meatus. Acoustic has got to do with what? Sounds, okay? So sound and hearing. So that should give you a clue that you're looking at vestibulocochlear as well, okay? So you can use the name acoustic to link to vestibulocochlear. However, just note that the facial nerve also accompanies the vestibulocochlear, okay? Then here you can see from 8, you go to 9, which is the glossopharyngeal, then vagus, okay? So 9, 10, and 11 also pass through one aperture, okay? 9, 10, and then 11 will pass through one aperture, the jugular foramen, okay? Then the hypoglossal, which is the 12, has its own aperture it passes through, okay? It doesn't share with any other nerve. So that will be named after the nerve itself. So hypoglossal nerve passes through a canal, and therefore that canal is called a hypoglossal canal. You can see very beautifully how the spinal cord has emerged as the medulla at this point, okay? So it means that inferior to this will be what? Continuous with the spinal cord, right? And what kind of dura enfolding is this? That should be the tentorium cerebelli, right? That will separate the cerebellum from the occipital lobes. So very nicely done here in this diagram. The vertebral column, since we are doing head and neck, we know that the vertebra continues through the neck. So we are interested in the vertebra within the cervical region, okay? So we need to learn the vertebra as well. So there are 7 vertebrae within the neck or the cervical region. It is labeled as C1, C2, through to what? C7. There's no C8. So remember that. Then you have thoracic vertebrae, which are also 12. Okay, and these are also labeled T1 to T12. Then you have the 5 lumbar, L1 to L5, and the sacrum, and then the coccyx, okay, which by evolution, as they say, has reduced its function, and therefore it has also reduced its structure as far as size is concerned. So with this, we can look at the side view, okay, of a human standing in an anatomical position. And then we are going to look at some important landmarks here. We are looking at spinal curves and then also vertebral regions, okay? Spinal curves and then vertebral regions. So let's first of all look at the spinal curves. You can have a curve here, which is known as the cervical curve, which is spanning between the protuberance of the occipital region or the occiput through the back of the neck towards the shoulder, okay? That's where you usually put your pillows. When you lie down, the pillow usually fills the cervical, space in order to help align you. Okay. Then you also have another curve, but interestingly, when you look at the direction of the curve, you see that the direction of the thoracic curve or curvature is opposite that of the cervical. Okay, so you can use concave and convex to describe these curvatures. Okay, so for instance, if you call this a convex, then obviously that should be concave. Okay, depending on how you look at it, one will be convex, one will be concave. Okay, so here you have another one towards the lumbar region. Okay, and then the sacral region also gives you another. So in all, how many do we have? 1, 2, 3, and 4 spinal curves or curvatures. Okay. And then you have these vertebral regions, which we have already mentioned: cervical, C1, C2, C3, C4, C5, C6, up to C7. And the thoracic T1 to T12. And lumbar is here, L1, L2. It's important for you to note all these because of what? Certain incisions that can be done, certain structures that exit the apertures, okay, of these vertebra. And then also when you're doing spinal tap, you want to collect CSF from an adult or an infant, you should know where to insert the needle, okay? So it's important for you to know the level at which these vertebrae lie. And sometimes you can use that as a surface anatomy, okay, which means that you can use certain structures to relate the level at which a certain vertebra is what? Lying, okay? So you can use the mandibulosternal joint, for instance, to determine a certain level of a particular vertebra, okay? Good. Now, since these vertebrae lie at different locations, they perform different functions as far as their locations are concerned. They also have different shapes and then architecture, okay? So looking at these three that I have brought here, cervical, thoracic, and lumbar, let's do a little comparison here. First of all, let's use the body, okay, or what other books will call or name centrum. Okay, so the centrum or the body. The cervical vertebra body appears this way. That of the thorax appears that way. That of the lumbar appears this way. Okay, so straight away, that should tell you that there are variations. Okay, there are variations. And so if they assume a dead body which has decayed, and then some way, somehow, if the vertebra has been dismembered, maybe there was an attack at a cemetery, and then you have vertebral bodies displayed all over, or bodies were traumatized by, let's say, some rebels, and they dismembered and disfigured the bodies before burying them, and you want to do forensics, for instance, you should first of all be able to tell which vertebra is located at which part of the body, okay? Because in that way, or at that point, you don't have the vertebra intact straight from the head region to the what? Let's say the gluteal region, for you to know that it is intact and in line, and therefore you can name them. If they are dismembered, once you pick this one, you should be able to tell that it is a thoracic vertebra and not a lumbar vertebra by even looking at the body. Apart from the body, you can also look at the vertebral foramen, okay, through which the spinal cord passes. Okay, So you can see that the way this arches for cervical vertebra, the way it arches is different from this thoracic vertebra and the lumbar vertebra as well. Okay, you can use other structures or other features, okay, of a vertebra to distinguish between one and the other. Okay, you can even see the bifid nature of this spinous process. Okay, unlike the others. So it's your duty as a student or your responsibility to study the bones and then be able to distinguish between the various vertebrae. Even for cervical, you know, we mentioned that the cervical can be listed from 1 to 7. Even that, you can still find differences within the cervical alone. Okay, for instance, the atlas and the axis. Okay, the first two cervical vertebrae even look different. Okay, so try and observe them in your own free time. Okay, now let's concentrate on the orbit. Yesterday we touched on the osteology part, so I believe this will be a very smooth sailing for those of you who were present. So this is the periosteum, okay? And then you have the periorbiter there, all the way. Then you have the muscle that is attaching the eyeball and holding it in position. That's the superior rectus. It also has an effect of giving the eyeball the, how will I put it? It gives it the ability to rotate, okay? Either rotate or superiorly observe things or inferiorly depress, okay? So it can raise the eye and then also depress it. We will look at all that muscle that we call the extraocular muscles. So this is inferior rectus muscle. You also have the inferior oblique. Okay, that is a suspensory ligament. Okay, so this is just a vertical section showing you a few features within the orbit. Most of the yellow portions you see here are actually fat. Okay, so you have a lot of fat there, and you should be able to tell the function of this. Okay, it insulates, it protects, okay, it shields, okay, to a large extent. That will be a chamber that is filled with fluid. You should know the name. And then there's another chamber here, okay? So if you have heard of aqueous humor and vitreous humor, that should be the lens. You have the iris and then the pupil. So you should know the bones that form the orbit, which we did yesterday. I believe if I ask you to mention, you'll be able to mention a few. The student should know the contents of the orbit and canals within the orbit. And then you should also know the structures that form the margins of the orbit. Okay. So as a recap, yesterday we saw these pictures. Okay, so that is the orbit. You should be able to name the bones that contribute to the formation of the orbit. So right away, at least, if you can't remember anything at all, your frontal bone, your zygomatic bone, your maxillary bone, at least these three major ones, you shouldn't forget. And there are a few others inside there, okay? The sphenoid bone, the ethmoid bone, all play a role. This is a side view. We observed that as well. And yesterday, I brought to your attention the reason why the lateral portions here are very stout compared to the inner margins, okay? And rightly so, you gave me the clinical significance. That's this portion, which is more lateral, is more exposed to what? External trauma, okay? So we have that. Then we have seen this already. So let's also observe the apertures and then foramina. You can see looking straight into the eyeball, the orbit, you should be able to tell these apertures. Who can tell me what this aperture will be? I have spoken a lot at length, and as you know, I talk a little and I engage you as well. So those who were in class yesterday, I can see 98, which is more than the number that were present yesterday. So what will be this opening? What will be the name of that opening? It's something we have seen even today, but because we didn't look at it from this angle, I just want to see a very smart person giving me the answer. Once you're able to tell me what it is, then we figure out what structures are passing through. Okay, so that the superior orbital fissure. Okay, Thomas, Tete, Amati, and then Rubin. Superior orbital fissure. Okay, great. Now, what are the contents? Bismarck also is right on point, superior orbital fissure. And let's look at the contents. What do you think will be passing through the superior orbital fissure? I mentioned a lot today. So let me see. Those who were listening. Oculomotor nerve, 3. Okay, good. So 3 will pass through it. What else? Abducent nerve. Okay. So 3, but why do you jump to 6 when we can go systematically from 3? It is easier that way, see? 3, 4, so that's the way you go about it. 3, 4, so trochlea is 4. Sometimes the names can be confusing, so as a student, that's the way I was learning it. I just mentioned the numbers. Once I know the numbers, then automatically I know the names. So 3, 4, 5. Okay, and the 5, we have 5, 1, as Ruben has indicated, trigeminal nerve 1. So automatically, you know 3 structures that are passing through it, okay? So 3, 4, 5, and 6. So basically, we even have 4 structures, 4 cranial nerves. Then also you can add a vein. A certain vein passes through that as well. What vein is that? Superior ophthalmic vein. Good. So if superior ophthalmic vein passes through the superior orbital fissure, and we know from here that if this is superior orbital, then obviously this one will be what? Inferior orbital fissure, without thinking. So that should be the inferior orbital fissure. So the clue is that if superior ophthalmic vein passes through superior orbital fissure, then inferior ophthalmic vein will pass through what? Your guess will be as good as mine. So that is a straightforward answer. We will not even waste time on that. Okay. So this is the significance of the bone, zygomatic bone, very, very strong bone, okay, to protect the eyeball, okay, from any foreign attacks, external attacks. We looked at the pterion also yesterday, so we will not revisit that. So there's a few texts. There are a few texts here for you to read. The orbit contains the eyeball and extraocular muscles. The eyeball is about 2.5 centimeters in diameter and occupies the anterior half of the orbit. The posterior half of the orbit contains fat. So you remember I mentioned that to you. So that is for emphasis. Apart from fat, what else? The extraocular muscles, then branches of cranial nerves, okay, as we saw earlier on in the slide, because of the superior orbital fissure, and blood vessels, okay, as well. Vessels and nerves pass through the orbit to reach the scalp and face. So that means that the orbit is so important because some of these blood vessels that actually supply the scalp and then the face will pass through those apertures, okay? So this is just for emphasis because we've seen that already. The bones of the orbit form a four-sided pyramid. And here I want you to note, okay, start thinking of the shape of a pyramid, the Egyptian pyramid or the pyramid you drew in your KG or nursery, because we are going to use that pyramid shape to describe a lot of things. So one of the things you are going to use your knowledge of a pyramidal shape is to note the base. So the base of the pyramid, the base of the pyramid is the orbital margin. So that is one point. Then you also have the apex. Apex of a pyramid is the optic canal. Now let's navigate around this sentence. The base of the pyramid is the orbital margin, and the apex of the pyramid is the optic canal. Does that make sense at all? Base of the pyramid is the orbital margin, and then the apex is the optic canal. So you use a diagram to explain this. So note this sentence, okay? Viewed from above, the medial walls of the two orbits are parallel to each other and about 2.5 centimeters apart, okay? The lateral walls of the two orbits form a right angle to each other. All right. So we've seen 2.5 centimeters here. We've also seen 2.5 centimeters. Okay, so the first 2.5 centimeters was describing the diameter of the eyeball. And then this 2.5 centimeters is also describing what? The two medial walls in terms of how wide they are apart. The bones of the orbit are lined with periosteum called periorbital. Okay, so we saw that earlier on. The bones of the orbit are lined with periosteum called periorbital. At the optic canal and the superior orbital fissure, the periorbital is continuous with the dura mater of the middle cranial fossa. This is loaded. So let's go over it again. At the optic canal, which we expect to be the apex of the pyramid. Okay, so at the optic canal and the superior orbital fissure, the periorbital, which is actually the periosteum-lined areas of the orbit, is continuous with the dura mater. And we know that the dura mater is a type of meninge. Okay, so let's use this diagram to explain the pyramidal base and apex. So look at it very well. You have to understand what the margin of the orbit is before you can even appreciate the base of the pyramid we are talking about. So for those who have stereogenic eyeballs, and they can actually decipher things in space. See, people are good. There are some people who can actually navigate spatial elements. Okay, so let's use that ability. That is the margin. Okay, that is the optic canal. So this margin is the base of the pyramid. And you know, a pyramid is pointed at the top, but its base is wide. Okay, so that is how this is going to be. So this will be the base, and then this optic canal will be the top or the apex. In other words, you are looking at a pyramid that is not actually sitting the way you always see a pyramid sitting down on the ground. In this case, it's like the pyramid has been uprooted and then put down, such that the base, which was originally on the ground, is now facing us. Okay, so that is the meaning of the whole pyramid architecture. Okay, so let's go through a few of the labels or the labelings. That is ethmoid bone. So let's add this ethmoid bone to the list of the bones that form the orbit. The ethmoid bone, we add it to the major bones like the frontal bone, zygomatic, and the maxilla. Okay, so ethmoid bone forms part. That is the lacrimal groove, and therefore you also have the lacrimal bone there, which is this. So the lacrimal bone. So these are the small bones that also help, bridge the whole orbit. So lacrimal bone. What else can we find? A very small one indeed here in orange or so. That is the palatine bone. Palatine bone. Can you imagine that the palatine bone is also located within the orbit? This is what the maxilla, okay? So the maxilla, as well as contributing to the margin, also forms the floor, okay? Helps form the floor of the orbit. All right, so that is the inferior orbital fissure. And that obviously will be superior orbital fissure. Okay. Then the zygomatic bone also helps form the lateral walls. Okay. We should be able to list all the bones. For instance, in an MCQ, I can easily set a question and list about 3 of the bones. Okay, here, and then intentionally bring an odd one out for you to choose which one does not. Like I'll say all the following bones form part of the orbit, except then I put ethmoidal bone, lacrimal bone, palatine, Then maybe vomer. Okay. But we know that the vomer will be in the nose. So let's look at the content. Also very important here, the content of the orbit. So let's first of all begin with the one we are familiar with, which is the superior orbital fissure. Okay, we already know that 3, 4, 5, and 6 pass through, and then also a certain vein, okay, a certain vein also passes through. So there you go. So you have all the yellow ones representing the nerves, okay, and that is a vein, okay. We know that that is the superior ophthalmic vein. Then when we come to the inferior orbital fissure, we see no cranial nerve at all, no yellow structure here, only this blue color structure, okay, which is the brother or sister of the superior one we see here. So that's just the inferior ophthalmic vein. Okay. So again, it will be very nice to set a question around the content of the superior orbital fissure or that of the inferior orbital fissure. Okay. So in the inferior orbital fissure, we can go like this. All the following are contained within the superior orbital fissure. Here we won't say except, but we will mention which specific structure passes through the superior orbital, the inferior orbital fissure, for instance, okay? Which of the following is a content of the inferior orbital fissure? Then we can bring a lot of those found in the superior orbital fissure. Okay, now let's move on to this optic canal. Optic canal. So we know that the optic canal contains the optic nerve and then the ophthalmic artery. You can see the yellow for the nerve and the red for the artery. There's no vein here. There's no vein. So just think about it. Look at how congested this superior orbital fissure is. If there's a tumor, okay, or any of these cranial nerves, okay, become enlarged due to a tumor, they keep enlarging and enlarging, growing bigger and bigger. What do you think would be the case in this room, superior orbital fissure? What do you think will happen? So I turn to you now. What do you think will happen if there's a tumor within the superior orbital fissure, a tumor on any of the cranial nerves, let's say the oculomotor nerve? Yes, who can share a view? What do you think will happen? As you think about the answer, do the same for the optic canal. And which of the two will be so severe? Is it when there's a tumor in the nerve here, the optic nerve, for instance, okay, has a tumor, and then oculomotor nerve also has a tumor? First of all, what will be the impact of each of them? And then we now compare the two, which of them will have very serious consequence. So I'm awaiting a response whilst we take a breath to digest everything I've said so far, okay? Let's assimilate. what we have said concerning the orbits so far. And then let the chat room be busy. 94 participants, you are a lot. At least a quarter of the class should be putting across what they think will happen. And then even as we wait for responses, please still go through the names of the bones, okay? Appreciate them. And those that have some grooves and all that. Okay, so let's see, somebody has responded. Frimpon Equia Manobia. If the optic canal has a tumor, there can be blurriness of vision or loss of sight. For the oculomotor, the ability to move the eye will be hindered. Okay. In the optic canal, when there's a tumor, there can be blurriness of vision or loss of sight. Because of what? I'm sure you are talking of the nerve there, which is the optic nerve. Okay. So the answer is correct. However, you have jumped one step. Okay. What is going to happen that the blurriness will occur? You didn't cite anything. What will happen before the blurred vision occurs? And then also for the oculomotor, the ability to move the eye will be hindered. Okay. So we'll take that. And then we'll come to know exactly the kind of movement the oculomotor applies. Okay. So that once we get to know that whether it depresses or medially or laterally rotates, then we can easily put the answer even a bit better. Okay. So from point here, you've done well. Very good attempt. Then let's see what Thomas Tete is saying. Thomas is doing so well today. He's going to compress. Yeah, so that is the word I was expecting Equia to state before even bringing the symptoms. So there's going to be compression. So it's going to compress the structure in the superior orbital fascia, causing paralysis of the muscles they innervate. Okay. Jose Frederick, it will stretch and compress other nerves which would hinder sensation. Okay, that is quite general. Stretching, you need to come again with the stretch. How does it stretch? I prefer the compress. Yes, compression. As for stretching, you need two extreme forces to stretch something. One force cannot stretch. Now one force can compress. Okay, now you've only touched on the nerves. What will happen to the nerves? How about the blood vessels? Nobody has said anything. Because if the optic nerve is undergoing any tumor invasion, it is not the only structure that is going to suffer. So how about, for instance, if you are dealing with the optic canal, how about the artery here? Ophthalmic artery. What will happen? Okay, so we have a new message there. Frimpong, a queer manobia comes again. There will be reduction in blood supply to the eye. So she says oxygenated blood supply will be reduced. Okay, that is true. As if you are lucky, there's still some space for the blood to even flow. Otherwise, if it constricts it completely, there's going to be some aneurysm. Okay, so there'll be no blood supply at all. So if there's no blood supply, then what is going to happen? The eyeball needs oxygen for respiration, aerobic for that matter. And then it also needs energy through that, okay? So I'm sure if you are supposed to write this as an exams, you'll be able to write a lot, okay? When you come to the superior orbital fissure, then it means you even include the function of the veins as well. That if there's an aneurysm there in the veins, then you can't what? Take out the used blood in that sense, where oxygen has now been depleted and you have a lot of carbon dioxide, the rate at which it will be what? Drained out will also reduce. Okay. All right. There are a few other clinical features we can look at, but you can read on that later. Okay, so the lateral wall of the orbit is stout, as we have learned already, and strong. But the part of the ethmoid bone that forms the medial wall is paper thin. So just think of a paper, a sheet of paper. Imagine how thin it is, and this is how the medial wall is ascribed as being, okay? And for this reason, it is called the lamina papyracea. Lamina papyracea. You remember the beginning of civilization in Egypt and the papyrus for paper, okay? Because they used to write on rocks and stones. Then paper started emerging in the form of papyrus, okay? You remember the scrolls. So as thin as a paper. So just imagine if this thin nature of a wall is actually brought to the lateral portion where the zygomatic bone is, then any slight abrasion or blow can actually cause fractures, okay? And you don't want to have fractures of the orbit because of how delicate the eyeball is very, very soft. Even in this pattern where we expect a lot of protection being in place, still, accidentally, sometimes something hits your eyeball. Even your own hand can hit the eyeball accidentally, and then you know how the pain is felt. And then you start tearing and all that. The inferior orbital fissure is a gap between the maxilla and the greater wing of the sphenoid bone, okay? So note that one as well. So this is another diagram we can use to navigate orbicularis oculi muscle. Okay, that's the muscle that is around the eyeball externally, not the extraocular muscle. So orbicularis is a facial muscle, okay? That is the orbital septum, superior tarsal plate, cilia, conjunctiva, inferior tarsal plate, orbital septum there, optic nerve, yellow, and bony floor of orbit. And that is the fat. That is a muscle that has an effect on the eyeball levator papillae. superioris muscle. Okay, so levator, it elevates, it helps to elevate. And then it's obviously going to raise the eyelid. Okay, so it's not directly related to an extraocular effect. Okay, but some way, somehow, it's attached to the eyelids. Okay, and so its effect can help elevate that portion. There are some glands that help the normal functioning of the eye. So tarsal glands are embedded in the posterior surface of each tarsal plate. So I think you saw the tarsal plate, inferior tarsal plate here, and then the superior tarsal plate. Okay, so within it is embedded tarsal glands. The glands secrete an oily substance onto the margin of the eyelid that prevents the overflow of lacrimal fluid or tears. Okay, so it's an oily substance. A similar oily secretory gland is found in the skin. What is the name of that? What is the other gland in the skin that's this type of secretion that the tarsal glands do? Let me see if you can be quick to give that answer. As for that one, when you're even sleeping and you are tapped, and that question is thrown at you, you should be able to answer. Okay, let's see. I have some responses. Sebaceous gland. Okay, so great. So Kingsley, you were asking about the function of the superior and inferior tarsal plates. So at least you have an idea what they do for now that the tarsal glands have been outlined, the functions of that. Let's correlate some clinical issues here with the tarsal glands. Even though they are helping, sometimes they can be troublesome. What trouble can they cause? See, if the duct of a tarsal gland becomes obstructed, a cyst can form, okay? And this will develop into this star. Okay, so the cyst will develop and it will be located between the tarsal plate and the conjunctiva. Then this tie or hodilium is an inflammation of the sebaceous gland associated with the follicle of an eyelash. So you should be able to distinguish between the two, okay? The sty and then the cyst. So it's good you were able to even answer the sebaceous gland, question. Because the point is that a gland always secretes its substance and it passes through a duct if it is a duct gland. Okay, that is why we have a duct gland and a ductless gland. The ductless will secrete their secretion into the blood directly and the blood will circulate it. But those that have ducts, when they secrete, whatever product they have secreted will pass through the duct. If the duct is blocked, then it means that the secretion cannot have its way out. And the gland doesn't know that the duct has been blocked, so it will continue secreting. So at a point, you are going to have accumulation of the product which is not being conveyed out. All right. It's like you have a factory, you are producing a product which the populace are not buying and you are not aware. Somebody packs it from the production unit and just bring it onto the compound of the company. And you, the boss, if you are just sitting there not observing things, you might think that once things are being carried from the production point, everything is being sold until you go out and you realize that everything has been packed there, just like what is happening here. So you have a cyst. In contrast, the sty is the inflammation of a sebaceous gland. So that can also become inflamed when the product is not going out. Okay, you end up having an inflammation, something like an acne, for instance. An acne or pimples, when you see it has not given way for the content to come out, becomes inflamed at a point, okay, until the exudate goes out. So you don't want these things to be happening close to the eye. I'm sure you've seen somebody with an inflamed eyelash, or let me take it this way, an eyelid, and then it causes the eyelashes also to have what? An inflammation at the base, because the eyelash is the hair, and you know the hair follicle has a base where it is connected to the skin. Okay, so it can be inflamed. This is a diagram just to clarify what we have said as far as the optic canal and then the superior orbital fissure is concerned. Okay, so Ross has shared something like calabash swelling, okay? So this is just a different view of another picture. 3 nerves enter the apex of the orbit. We know that by now, what the apex stands for. You have the frontal nerve, which is a branch of V1. Okay, so V is the trigeminal nerve, the ophthalmic branch. You have a frontal nerve. Then anteriorly, this nerve divides into the supratrochlear nerve and the supraorbital nerve. Then you also have the lacrimal nerve, which passes through the superior orbital fissure. You also have the trochlear nerve. Okay, so these are the 3 nerves that enter the apex of the orbit. Now, you see this diagram is similar to this one. However, there's an introduction of this circular ring, okay, which is also so important. Okay, these are circularly arranged extraocular muscles, okay, and then the content. So this time around, you see that this circular arrangement is encircling the optic canal and then the inferior portion of the superior orbital fissure. So let's look at the content here. So you have superior division of the oculomotor nerve, you have the nasociliary nerve, abducent nerve, and then inferior division of the oculomotor nerve. These muscles, which we describe as the extraocular muscles, are named accordingly. So that's superior rectus. Remember the levator papillaris superioris we mentioned earlier on, okay? That is not part of the extraocular muscles per se. So this is superior oblique, that is medial rectus, inferior rectus, and then lateral rectus. I have put this here to simplify their functions, the names and the functions, okay? So that is LR will stand for lateral rectus. Let's locate lateral rectus here. We expect it to be lateral. Who can tell me which eyeball is this? Is it the left eyeball or the right eyeball? Is it left or right? Before I even continue my explanation, let me be sure that people are navigating right, okay? Let me see. Right. Everybody says right. Okay. So that's the right eyeball. That is true. So you can even use your own as a way to demonstrate, okay? So look at your You can't even look at it, but you can imagine. Yes, just imagine it there. So on the right side, the lateral side, so in this case, you can even use your hand, okay, to signify that region. It means that the lateral rectus, if you use your right hand just on the lateral side of the orbit, it tells you that the lateral rectus is indeed lateral. Okay, that's why the name is so. The lateral rectus 6, LR6. The 6 stands for what? What do you think this 6 will stand for? The LR is lateral rectus, so 6 will be what? What will be the 6? Okay, let's see what somebody says. Abducent nerve, Estacofa, yeah. All right, so the lateral rectus is innervated by what? The abducent nerve. So that is the lateral rectus. Lateral rectus muscle. Okay. Now this is the abducent nerve. See, VI 6. So look at where it is. See that the abducent itself is also lateral in relation to the rest, in relation to the superior division of the oculomotor, the nasociliary, and then the inferior division of the oculomotor. You can see that. And therefore, because the abducent is most lateral, it makes sense that it will innervate this lateral muscle known as the lateral rectus. Okay, then SO4, superior oblique, SO, superior oblique. Let's look for superior oblique. That is superior oblique. Superior means that we are supposed to see it above, okay? So it is superior and it is obliquely aligned or situated. So superior oblique, SO. Then 4, obviously, now that we know that the numbers are standing for the cranial nerve, this 4 will also stand for what? The 4 will stand for what? IV here, trochlea, okay? So it also innervates that. Then 3 for all others. The 3 is oculomotor. So oculomotor innervating all the other extraocular muscles. Okay. Okay, so Thomas Tete, Kweku Pamford, Esther Koffa, A.J. Ebenezer all said the trochlear nerve. Okay. So now we've taken the muscles out, but we want to use, the outline that they formed, the outline that we can get out of that as a common tendinous ring. So we are labeling that as what? A common tendinous ring. Look at this. Let me go back. You see these tendons that are actually holding the muscles and connecting them into a circular form. So that is what we are now using. And we are saying that that forms what we call a common tendinous ring. It actually looks like a ring. See? A ring that can fit somebody's finger. So that is the tendinous ring. So what are the contents of the tendinous ring? What are the contents? That is a very easy MCQ question to settle. See, so the tendinous ring will contain optic nerve, ophthalmic artery, and in fact, the optic canal itself is also located within it. Then you have what? Superior branch of the oculomotor. Then you have the nasociliary branch, abducent nerve, inferior branch of the oculomotor. Okay, so note that. So structures that pass through the common tendinous ring has been listed here. Optic nerve, superior and inferior divisions of oculomotor, nerve abducent, nasociliary. So this is just for emphasis. Okay, so know that. Okay, so this diagram is up again. Topography of the orbit and its relations. Okay, so just as we use the orbit to signify a pyramid, and therefore we had the base and the apex. We can also have the roof, floor, and walls, okay, of the orbit. It's just like a room. Every room, including where you are now, unless you are in an open place, definitely you will have a roof on top of your head. You have a floor on which your chair or table is sitting and your feet is also on the floor. Then you could have some walls, okay, if it's your hostel or room, you might have some wallpapers or curtains or whatever, or even the windows will be in the wall. So it's just like a room, okay, a feature of a room. So that is how we are observing this orbit. So how will you relate the roof of the orbit? What are you going to relate it to? It is related to the anterior cranial fossa. Is that true? So if it's a physical class, I'm sure you all have a resounding voice that yes. And for those who came for the first class yesterday, you know what the anterior cranial fossa is. What will the anterior cranial fossa contain? Which part of the brain will sit in the anterior cranial fossa? Okay, somebody has quickly answered frontal lobe. Good. Thank you. Who was that? Let me check the name. Hey, Thomas. Thomas is doing so well today. Ruben is also following up. Gabriel Dankwa, frontal lobe. Okay. The medial wall of the orbit is related to the ethmoidal cells. And then the floor is related to the maxillary sinus. Maxillary sinus, yesterday, yeah, so Frimpong Darlington also says frontal lobe. Those who were listening yesterday, I'm sure this maxillary sinus will sound so familiar. You remember the X-ray picture we saw yesterday? That I was describing the spaces within the maxilla, okay? Where I said that when you get flu or common cold, for instance, you get congestion and all that. See? So the floor of the orbit is related to that. And the medial wall is related to the ethmoidal cells. So these ethmoidal cells are also just like the sinus, the maxillary air sinus, okay? Ethmoidal air cells. So blood supply or drainage, that's as we looked at the clinical significance. If there is a tumor within the optic canal or superior orbital fissure, what will happen to the nerves and then the blood vessels? And you said it right, that there will be constriction and compression and all that. So blood may not flow well, oxygenated blood, and then also you can't drain the metabolic waste, including carbon dioxide. So let's look at this. This is the internal carotid artery. Remember today we started with arterial supply. Internal carotid artery. Where is it coming from? I will need an answer. Internal carotid artery. Where is it branching from?
From the neck.
From the what? Neck.
From the neck. We have the external and the internal carotid artery. The internal goes to the brain and the external for the facial, I think. So, yeah.
Okay, so the internal, you are doing what? So the internal carotid artery is coming from which one? What is giving rise to the internal carotid artery? What is branching to form internal carotid artery? Is that what? You see, before you get the so somebody has answered in the chat room. Okay, so that will be common carotid, right? So common carotid will branch into internal carotid and what? External carotid. So I only needed the common carotid. You see, so the common carotid is what will branch into the internal carotid and then external. Then when we also add that what is also branching into the common carotid, for instance, then you can also relate it down towards the arch of the aorta where you have the brachiocephalic trunk and all that. Okay, good. I like your responses though. So that is it. So let's see something. Internal carotid artery. Then you have ophthalmic artery. So look at it. A branch of the internal carotid artery, ophthalmic artery, going through what? What kind of aperture is this? What canal is the ophthalmic artery passing through? I'm waiting for an answer. See, this is a different diagram, so I want to be sure people are following and they can remember. Oh, Esther Kofa, it's not optic tract. So I'm sure you meant a canal. Good. So Usu, Georgina, Ellen, Sando, Daniel Takinda, Ross Wesley, all say optic canal. Good. So you see, this is the way you familiarize yourself and you never forget. Okay, from today, I don't think you have to even revise in order to remember that optic canal carries ophthalmic artery. As for the optic nerve, it's a bonus. You know automatically that optic nerve primarily goes through the optic canal. That is its designated pathway. But what you now have added is the ophthalmic artery, which is good. And then you have also added that the ophthalmic artery is a branch. So the answers are now flowing in. Barfor Kobna says same. Okay, I want to take you back to something. The arterial supply, taking it back here. Look at this ophthalmic artery here. You see? And look at this internal carotid. See? Ophthalmic artery is branching off the internal carotid artery. Do you see? Then, obviously, that will be external carotid artery. So the question I first asked was, what is giving rise to the internal carotid, or what is branching to give the internal carotid? And that should be what? The common carotid. Okay. Common carotid. And then I also asked that we can even ask what is branching off to give common carotid. That is when you come close here and say brachiocephalic, whether you are talking of the right or the left. So when you're talking of the right, then that is your brachiocephalic. If you are talking of the left, then it is the left common carotid. Because as for the left common carotid, it branches off straight from the aortic arch. Okay. It's the right one that starts as a brachiocephalic trunk. Brachiocephalic trunk before it now divides. Okay. Good. So it is this ophthalmic artery that will pass through the optic canal together with the optic nerve. Okay, so that is it. Okay, so let's see. Okay, so we are here now. Let's also journey with this ophthalmic artery and see how it's going to behave. Okay, so ophthalmic artery here, let's see how is it behaving. It is branching into two here. Okay. Now, when it branches into two, it continues and then gives off different branches as well. Okay. So you can see that it's giving off these posterior ciliary arteries. You know of the ciliary muscles of the eye. So posterior ciliary arteries will mean that it's also going to supply what? The ciliary muscles of the eyeball. Then also it continues as what? Posterior ethmoidal artery. You know, the ethmoid bone is in the medial wall, remember, and it's very weak. Okay. All right. Then you also have anterior ethmoidal artery, then supratrochlear artery, supraorbital arteries. Okay, so on and on and on you go. You have the ophthalmic artery as a major one. Then you also have the ophthalmic veins. Remember, superior ophthalmic vein, inferior ophthalmic vein that passes through the superior orbital fissure and inferior orbital fissure, respectively. They also have an angular vein, okay, which comes off from the facial vein. Okay. Now remember we said that most of the blood vessels that supply the scalp and the face also pass through the orbit. Okay, so look at this. You see here, there's a foramen here where the superior orbital artery and vein will what? Emerge. Okay, this is the inferior orbital artery. That is the angular artery and vein, which branches of the facial artery and vein. Okay. That is why you don't want to trouble your orbit. Okay, even look at how these superficial temporal artery and vein are lying down on the lateral side of the zygomatic bone. When there is a blow, okay, or there is a laceration with a blade or a knife, it can easily cut through this, okay? All right. These are the lacrimal artery that also goes to the lacrimal gland, the tear gland. So it's important for you to appreciate this architecture. Okay. So as we did with the earlier two slides, that also showed the course of the ophthalmic artery. This is also giving you another picture, okay? So obviously optic nerve and then ophthalmic artery through the optic canal. You have the central retinal artery. You can see that also branching off from the ophthalmic artery. It goes through the substance of the optic tract, the optic nerve, okay? Optic nerve there, so it's accompanying it down there. Then you have the lacrimal artery. So see the lacrimal gland, see that the artery goes all the way into it to supply it. Then you also have the supratrochlear artery, which will go to the point towards the trochlea. And then also you have the anterior ethmoidal artery and all that. So take your time. When you get the slides, you can observe them. Then this is the vein. So very beautiful. Superior ophthalmic vein going through what aperture is this? This is another angle at which we are using to decipher what type of canal or foramen or whatever. So what is that? That's the superior orbital fissure. See? The superior ophthalmic vein. But when you look at where these ophthalmic veins are draining towards, they are draining towards this cavernous sinus. See? The cavernous sinus. So we have introduced another term, cavernous sinus. There. Then you have the inferior ophthalmic vein also through there. Okay. All right. So clinical consideration, anastomosis between the angular vein and the superior and inferior ophthalmic veins are of clinical importance. Why? Infections of the nasal cavity. So we are talking of the nose region. Upper lip, okay, even your upper lip, your cheeks and forehead may spread through the facial and angular veins into the ophthalmic veins and then into the cavernous, and this is dangerous. Let's go back and appreciate this thing very well. You see, look at your angular artery and vein. You see, it's around the nose and the cheek, okay? Then you have the transverse facial artery. So if you are picking some pimples or acne, you know it's full of bacteria, you break it and then it finds its way into any of these blood vessels. The likelihood that, especially in the vein, it will drain all the way, okay? So it will drain. See, from the forehead here, it can drain into the superior ophthalmic vein all the way into the cavernous sinus. If it's down here too, the same way, goes to the inferior ophthalmic vein, joins that cavernous sinus. And if you know where the cavernous sinus is, it's sitting very, very close to where the infundibulum is, okay, the pituitary. They are very, very close, and it's actually in the substance of the brain, okay? So that means that it's carrying the infection and then whatever microorganism is within the pus. Okay, so infection of the nasal cavity, upper lip, cheeks, and forehead may spread through the facial and angular veins into the ophthalmic veins and then into the cavernous sinus. Thrombosis of the cavernous sinus may result as a result of that, okay, leading to involvement of the cranial nerve 6 and dysfunction of lateral rectus muscle. Okay, so just an infection in these areas that are not linked to the eyeball directly can cause this dysfunction. So if you know the function of the lateral rectus muscle, then that should give you a clue to how the symptom is going to be. Okay, so muscles in and around the orbit. Orbicularis oculi muscle, we saw that earlier on in the lecture today, so that is it. So I told you that is a type of facial muscle. muscle for facial expression. So you have the orbital part and then palpebral part. So the palpebral part is on the eyelid, okay? And then the orbital part is more around the orbit, and then getting to the portion inferior to the forehead, okay? And lateral palpebral ligament is the medial palpebral ligament. Okay. So these are the extraocular muscles. Let's quickly go through their functions using this diagram. Then we'll draw the curtains, okay, for today. So superior, inferior. So this arrow shows elevation. This is depression. When the eyeball goes down, it depresses, it goes up, it elevates. When it goes on the right, it is what? Adduction. When it goes towards the lateral portion, so this is left, let me use that. So we are using, let's say, the right eyeball, okay? When it goes to the right, in anatomical position, this will be the right, okay? But on the screen, this is on your left. That will be abduction and adduction, okay? Because this is medial with relation to the nose, okay? Then you can also rotate the eyeball either internally or externally. So medial rotation or lateral rotation. So let's see. Lateral rectus that we said can cause a problem due to what? Infection on the cheek, forehead, and what have you. What does it do? It abducts. Okay, so it abducts. Medial rectus adducts. Superior oblique, inferior oblique. Okay, so superior oblique will depress, inferior oblique will elevate but also rotate in a way. Okay, then superior rectus, the inferior rectus also do some depression, medial rotations. Okay, depression and elevation. So you can use this diagram to detect when you are testing for a muscle. For instance, you are testing for superior rectus. This is how the patient's, eye should move. Direction to move eye when testing muscle. Look laterally and upward. Okay. And then you can do for the rest. Okay. All right. So we'll end with this intrinsic muscles of the eye, which are only two, so you can take that away easily. Sphincter pupillae, dilator pupillae. Okay. This helps with the constriction or dilation of the pupil as far as the iris are concerned. Okay. So tomorrow we'll start with the innervation of the orbit. Then we continue. Okay. Okay.
He says it via Zoom.
Pardon?
Is it via Zoom?
He said, is it via Zoom? Is what via Zoom?
Yeah.
Yeah, it's via Zoom.
The class.
Yes. Yeah, the class is Zoom. Yeah, it's via Zoom. So, class rep, send me your email, okay? And then let me see how I can share some of the slides or the recording. Okay, so thank you very much for your audience. We will end here, continue, I think on Friday. So let me put in my telephone number. So that if anybody wants to contact me. So, hey, the email address I have two, one from Samuel Owusu and one from Lydia Chumese. I guess you are the two reps for the class. So I will note the email addresses. Okay, so you will hear from me, Chumesi, and then Samuel. Okay, you hear from me, but it will not be tonight. Okay, bye-bye.